I'm not representing CDC. I'm representing WHO now in this chairing role. It's really my pleasure now to be able to step in and support. And I know it's important to have these conversations, even if we're at the end of a very long and busy week. So it's my pleasure now to introduce Dr. Clarota, who will be introducing herself on her topic on how we can move forward with sustainability and integration. Thank you very much.
Thank you very much. Good afternoon, everyone. I'm Clarota Gwanzura. I'll be presenting from our innovations monitoring DSD implementation in Zimbabwe. I'll try to make it within the 7 minutes. So Zimbabwe has been implementing differentiated service delivery since 2017. Though we had been differentiating services earlier than that. We had started with the outreach model in 2009, but in 2017, that's when we then made clear guidance and a strategy on adopting more DSD models and also scaling them up in the country. As of June 2023, this year, we had approximately 472,000 people living with HIV enrolled in different DSD models offered within the country. So for a program to know how well it is doing, there's always a need for an M&E system with the monitoring frameworks, data collection and reporting tools, and a system of analysis. When we started expanding differentiated service delivery models for art in Zimbabwe, we really didn't have a system for us to be able to track and to know how we are performing. So we had to come up with a system that would allow us to get the data and for us to monitor our progress with implementation. At that time, when we also started with DSD implementation, we also became a member country to the ICAP convened Sequin Learning Network, which is a platform that focuses on accelerating DSD implementation for people living with HIV. So within that network, our first step was working within that network for co-creation of an M&E for DSD, a monitoring framework. From that framework, countries were encouraged to then prioritize the DSD indicators that they would track, picking from the framework that we co-created together with the rest of the member countries. So after that creation, we then conducted a multi-stakeholder technical working group meeting. In this technical working group, we've got Ministry of Health, we've got implementing partners, we've got recipients of care from the different organizations that represent them, and we also have funders within that technical working group. So we then prioritized indicators that we're going to track, and 4 main indicators: DSD uptake, DSD coverage, healthcare worker workload, and also client satisfaction were the 4 main indicators that we prioritized. 2 of those, that is the client satisfaction and also the healthcare worker workload, were going to be assessed through survey-like system. Our quality standards for monitoring DSD were also then later developed from those indicators as well. In the next step, we realized that our M&E systems, they were going to take longer, which is usually the case, for them to catch up and to be able to give us the data points, the reporting tools, just the source documents for us to be able to report on these indicators. So we then had to come up with a system that we could use in the meantime for us to be able to get that data to start monitoring. Therefore, we developed a reporting tool that was going to be used by our implementing partners. So as you can see on the slide, Zimbabwe has got 10 administrative provinces. We've got implementing partners who are supporting all of those provinces, and the facilities that are supported by our implementing partners, they cater for approximately 80% of all the people living with HIV on ART in the country. So this was a low-hanging fruit. We already had a platform that we could use for us to be able to get the data that we needed. We developed this data collection tool, which is based in Excel for reporting quarterly on new enrollments and also the cumulative numbers of people enrolled in DSD models disaggregated by model and sex. Together with the SI teams, we validated the tool and we sensitized the rest of their teams on how to use the tool. The initial analysis that we did when the tool was deployed, we did it together with the implementing partners so that everyone was on board. Later on, we also added multi-month dispensing to that tool. The slide that you are seeing is just giving a picture of the two systems running parallel to each other. The simplified tool that we're going to use is the one that's on top, running from 2018, and we are still currently having it. And then at the bottom, these are some of the adaptation activities that were happening to the national M&E system to be able to report on these indicators. Once we had this tool in place, we were now able to track our prioritized indicators. You can see from the slide, we could now track our DSD model mix, which increased steadily from 32% in 2019 to 47% in September 2023. And this is a percentage of all people living with HIV and not just a small proportion. We could also track our multi-month dispensing for the same period, which increased from less than 5% in 2019 to 49% as of September 2023. And we also scored an immediate improvement in the capability maturity model staging for our uptake and coverage because we now had indicators that could track, that could help us to assess the maturity of those domains objectively. We also were happy to note that when we did data triangulation, the reports that we're getting from our quarterly reporting tool was consistent with other sources of the same data. So we do DSD review meetings, and with those DSD review meetings, the coverage that you are seeing there, it was within the acceptable variance range, and that gave us more confidence in continuing to use this tool. So some of the lessons learned, in summary, we learned that simplified systems running parallel to the national HMIS can still provide relevant and critical alternatives to answer immediate questions. The use of this tool was able to allow the program to grow whilst allowing us for time for the national system to catch up. Working with all stakeholders always brings about better results. I mentioned how we worked with our implementing partners who were already in the districts implementing and reporting on other ART-related indicators. And we were able to monitor implementation and course correct during implementation due to the information that we obtained using this tool. Our next steps include continuing the use of this reporting tool to run parallel to the newly adapted DHIS or HMIS systems so that we can triangulate the results until we are ensured or until we are happy of the data quality from the adapted systems. We are also going to start data analysis from patient-level systems that have currently been scaled up so that we continue with triangulation and improvement. This is the end of my presentation. Thank you very much.
Thank you. And you know what? I think you're now my favorite presentation because we're always looking for what are those innovations that can follow people in the DSD models and that we're seeing that we're having outcomes that are similar, if not better. And so I have to congratulate you. This is the first time I've seen a real comprehensive approach to M&E around the DSD models. So what a fantastic innovation. Congratulations. So next, it's my real pleasure now to introduce Dr. Carolyn Govindson, who's going to present on and standing in for a colleague, presenting on optimizing sample courier, if that's correct. Nope. Using visual and interactive BOK bead bottles. She'll present and introduce herself and her topic. Thank you very much.
Morning, everybody. My name is Caroline Govertson, and I am speaking today on behalf of Dr. Neo Ndlovu, the PSI team, and the Indlela team who are part of this evaluation. My presentation is on increasing HIV literacy using an amazing innovation called the BOK bid bottles. Next slide, please. So it's really important for people to understand the importance of both initiating and sustaining treatment, HIV treatment. But this information is not always received or is not always easy to understand. And so people don't always get the importance, like I said, of treatment initiation and continuity. This leads to poor adherence and also just poor HIV outcomes all around in terms of adverse effects like morbidity, mortality, and transmission of the disease. So what we need really are affirming and clear messaging that is able to better communicate the benefits of art. What we set out to evaluate is an innovation that we thought would be the solution to this, and these are called the BOK bead bottles. These are a set of bottles, 3 bottles. They are a simple and interactive tool that is used to explain concepts like U equals U, concepts like viral load, and viral suppression in an easy to understand way. The first bottle has got black beads and 1 red bead. The second bottle that you'll see on the picture has got about 3/4 of the black beads and 1/4 of the red beads. The third bottle has got, again, the majority of red beads and only 1/4 of the black beads. Next slide, please. So to explain this, the black beads with the mix of the black beads and a few of the red beads, this is how is explained to the participants or to the community, whoever the bottles are being used to explain the concepts to. This first bottle really is what the body looks like at diagnosis. There may not be symptoms, but the HIV is still present. And so the HIV is multiplying and it is able to make someone sick, and also it is transmissible. That is, it can be transmitted to someone else. So at this stage, someone has got 2 choices. The first choice would be to start treatment. And that would lead us to the bottle on the extreme right, where the HIV begins to reduce and you are not able to transmit the virus, and the virus itself is not able to make you sick. The other choice would be to defer treatment or to delay treatment. And without treatment, HIV then overtakes the body. Then you will see the increase in the red bottle, in the red beads that represent the HIV virus itself. And this presents a high risk of falling sick, as well as a high risk of transmitting HIV. Next slide, please. And so what we sought to do is to evaluate the use of these bead bottles in HIV counseling for people living with HIV. The study was done in KwaZulu-Natal in South Africa between November 2022 and January 2023. We enrolled 80 people living with HIV, some who were newly diagnosed with HIV, and some who had been lost to care and were now re-engaging in care. Before the counseling session, people were asked, there was a survey where we evaluated knowledge, attitude, and perceptions around HIV. The participants were then counseled using the BOK bead bottles. This was individual one-on-one counseling, and they were counseled on concepts, like I said, the viral load, viral suppression, and essentially U equals U. The participants were then given another survey, and this, I have to say, was immediately after the counseling session. They were given another survey where they were asked questions again on knowledge, perceptions, and attitudes around HIV. And then they were asked about acceptability, feasibility, and appropriateness of using the BOK bead bottles themselves. We then took a subset of these 80 participants, and with 20 participants, we had in-depth interviews where we asked them about their experience using the BOK bead bottles, what it elicited in them, and how it impacted their thoughts around HIV and their understanding. Next slide, please. So what I'm going to present to you today are the results of the thematic analysis that we did with the qualitative interviews, and also the qualitative interviews, and then also the results of the surveys that we did, which were quantitative. Next slide, please. So in terms of the validated tools that we used to assess acceptability, appropriateness, and feasibility, the scale measures these things out of 5 as the maximum 5 positive acceptability, appropriateness, and feasibility. And these bead bottles measured over 4.5 out of 5 for all these measures using these validated tools. We then also asked the questions around understanding of how art works, viral suppression, U equals U, and then just the overall confidence that participants had with regards to transmission of HIV to others, how HIV worked with regards to protecting others whom they had relationships with, and then also confidence in the protective benefits of art for themselves. So as you can see, there was some really big jumps in terms of just the percentages of understanding of how art works. It went from 13% to 93%. Understanding of the concepts of viral suppression, which were initially not very clear to a lot of people, this went to 20%, from 20% to 99%. And then understanding of the concept of U equals U, which is really one of the important aspects for people to understand when taking treatment, this went from 6%. There wasn't a very clear understanding of this concept, and it went all the way to 99%. And then confidence on protective benefits on art for oneself, which was over half, 64%. This went all the way up to 100%. And confidence for protective benefits for sexual partners, which was a little bit lower than for oneself. It went from 58%, and this went up to 94%. Next slide, please. The next point I want to talk about is that participants were asked outright, like, how do you feel that your understanding of how art works is? And this is their perception, and this is how confident they felt in their understanding. And you'll see that we had a Likert scale that went from extremely well to really not understanding it well. And if we look at essentially the extremely well, understanding how art works extremely well, this went up from around 12% to over 90%. So the confidence in how they felt that art was working and that they could explain art to someone else and they understood how it works, this really made a big jump after the explanation with the BOK bead bottles. Next slide, please. I'm going to go to some of the qualitative results that we have, and I'm going to talk a little bit about some of the themes that we were evaluating. Next slide, please. So the themes that were coming out of the qualitative work really was visual representation, and that's that participants really felt that this was an attractive and visual representation of some really complex issues that they hadn't been able to understand before, that it improved their understanding of viral adherence, that it gave them positive emotional response in how they felt about being HIV positive and about HIV itself, that they felt that this could really be beneficial in communicating these concepts, not only to people living with HIV, but they mentioned in the qualitative interviews other groups that they thought would benefit from using some of these tools. And then essentially that it really did change the priorities around taking HIV medication and visiting the clinics. Next slide, please. So what I have on the next slides is just some of the quotations that we found in a qualitative work that I'm going to be using to illustrate some of these themes that we've talked about. So in terms of visual representation, this was really that the beads attracted attention and they represented complex concepts visually. And in this quote, the person said, "The bottles are the best. As the colors explain everything better, they are attractive and clear all the confusion." So this is the visual representation of the beads and the colors that they had. Next slide, please. This one is the one on just emotional response, and that these bead bottles generated a positive emotional response. And you'll see here there are terms like happy and motivated that this particular participant used in saying that I am happy as I gained more knowledge I was impressed, never received such kind of counseling, and am motivated to take my treatment. Next slide, please. And again, importantly, it improved understanding of the connection that is between taking your medicine and treatment adherence and viral suppression, which was not always obvious to people. So this participant says the bottles themselves got my attention, especially seeing how one can move from one bottle to the next. And the last one really is around just the changing of priorities and decision making. They have changed my opinion on how I should take my medicine, and I will take them correctly. Next slide, please. Sorry, this is the last one. And again, this was around questions about who else do you think could benefit from this? How else could we communicate this information, and who else to? And here they said that it would improve communication with different groups. Amongst the different groups that were mentioned, they mentioned just the community at large, and not necessarily only people that were dealing with it, that were infected with HIV. And there was mention of stigma and how this could help alleviate some of the stigma within the communities. And what this participant said was, I wish it were possible to educate the people, even calling community meetings to teach them about HIV and demonstrate treatment using bead bottles. So again, this is a use case that was coming from the participants themselves. So in conclusion, I'd like to talk about what we're thinking about the bead bottles, what we've learned about them, and what we think should be happening going forward. These bottles have been implemented across Zimbabwe, across South Africa, and really this is just the starting point of building an evidence base of how well they actually work in implementation. So they are a visual and tactile representation of complex clinical issues that are really difficult to grasp, even sometimes for those that are healthcare professionals and that are explaining them. This makes it easy for the professionals themselves to understand, and for the participants themselves. It makes it very easy. And then we actually did see an increase in treatment literacy among the people living with HIV, and there was no difference between those who were re-engaging in care. There was a benefit there as well. And then also those who had just been newly diagnosed and were starting care. And again, this is a low-cost intervention. I wish I would have brought the bottles, but essentially it is a bottle with some beads, and they're easy to integrate into the existing system. They're easy to make, and they're low cost. So that's a really important thing to keep in mind when thinking about interventions that you need to integrate and implement in low-cost income countries, in low-income countries. Again, like I said, easily integrated into existing HIV treatment and adherence counseling programs. And lastly, I think more work really needs to be done to build an evidence base, to co-design with communities, and really understand how best this intervention can be used most effectively. It's important to prioritize implementation science and research for the use of BOK bottles as a health communication tool. Next slide, please. We've written up a paper on this evaluation of the BOK bead bottles. We've got a behavioral insights report that we've published on our website, Indlela at Hero, and we've got a preprint, and we're hoping that this will be published soon. So if you would like to read a little bit more about this evaluation, you're welcome to. These documents are on our Indlela website. Next slide, please. Next slide, please. I'd really like to thank the participants in KZN that were a part of this evaluation, the study sites and their staff, the study team. And I'd also like to make a special mention of PSI, Meshboxology, who were the ones who, in a co-design process with stakeholders, were responsible for the design of this innovation that is the BOK bead bottles. And I'd like to thank the Indlela team, that behavioral science team that were part of this evaluation as well. Thank you.
Thank you. Another very interesting innovation to help explain such an important topic that is difficult. Sometimes we have very difficult viral load algorithms. What does it mean? So we need to pair up with WHO because these BOK bottles could really help get that message of U equals U across and what is undetectable versus suppressed. So I really like that innovation. So thank you. Excellent. So now it's my pleasure for the last presentation of the day, Hilary Lumano, who will be presenting, on another innovations in sample courier, linking viral load to corporate samples. I think this is another great innovation. It's really sad that this is coming at the very end of the meeting because so much can be learned from these innovations. Over to you, Doctor.
Okay, thank you. Just to correct you, the topic is optimizing sample courier for improved health outcomes on the Copper Belt.
Okay.
Yeah, good morning, everyone. My name is Hilary Lumano, representing the USID SAFE project from Zambia. And what I'll share with you this morning is basically how we optimized our sample courier mechanisms on the Copperbelt province in support of the ART program. So the SAFE project was mandated to support the Ministry of Health with the ART program and all the related aspects of the program. So what I'll share is basically how we integrated other sample types into the viral load courier system. Next slide, please. By way of background, we developed a robust courier mechanism in support of the ART program, which basically initially started with viral loads and EID. The courier mechanism basically managed intra and inter-district routes. And what we noticed along the way was that other sample types were neglected because the focus was primarily on early infant diagnosis and viral load samples. So in 2023, the need arose to leverage an existing courier and include other sample types because, as you know, in the ART program, there are other specimens that are required to move. Different tests are required by clinicians to manage these patients, apart from the core tests, which are viral load and EID. And a comprehensive review of all the variables involved was conducted to appreciate what would be required. Next slide. The other sample types that were neglected include drug resistance testings, HIV drug resistance testing, HIV-1 recency, TB and TB culture, CD4, human papillomavirus, commonly abbreviated as HPV. Then we had hematology and chemistry samples that were equally neglected, and histopath and cytology samples. So these were the sample types that were neglected. What did we do? We did a baseline physical geographical assessment and road mapping across all 9 districts and 148 supported facilities. So this is on the Copperbelt province, which is a very urbanized province of the country. And a descriptive overview of courier services was elaborated, and we noted that the viral load and EID sample movements moved between 5 and 152 kilometers, maybe slightly over that. And what we were going to exploit and leverage and take advantage of was a total of 20 motorbikes and 3 vehicles, which facilitated transport for viral load and EID for 160,000 ART clients. We quickly evaluated storage and shipment requirements. We described them so that we could appreciate any unique or complicated needs. We further used an electronic tool that we use to manage the sample chain of custody. This electronic tool is called eLabs. We used that to look at what the viral load turnaround times were, and we were trying to see if we could mimic those viral load turnaround times and see if we could bring them into the other neglected sample types and improve ultimate outcomes. Next slide. So this is just a picture, if you like, of the various districts. In green are the district hubs. So there are 7 districts there that had to move samples. And the orange you see there are facilities that are moving samples into district hubs. And as they move from the green, they go into the PCR labs, which are centralized facilities where viral loads are being tested. This is the mechanism that we are going to piggyback on. We are going to leverage these movements, these mechanisms to incorporate all these other sample types and ensure that they all gain benefit from what we termed the baseline courier mechanism. Next slide. What did we do? We engaged, the process started by engaging facility leadership on the need to integrate VO and EID sample movements with others. So what we further did was, apart from facility leadership, we also engaged district leadership and provincial leadership to explain to them that the fundamental courier system that was working was now going to pick up different sample types and was going to begin moving these samples at the same time. All levels of healthcare providers were therefore alerted on the need to include other sample types. And what we further did was the motorbike riders and vehicle drivers were brought into one place, and we run them through the need to increase the scope of samples picked up and what the actual pickup points were. It was very important for them to understand that they were not only going to be looking for viral load and EID, but they would look out for several other samples. The riders and drivers were further mentored on safety requirements as the scope of pickups increased. What we did and what we are still doing is that the safety requirements are an ongoing intervention. We continue to train because as the sample types continue to increase, the needs for safety also increase. Next slide. What were the outcomes? The summary of the outcomes is we've begun to see a steady and gradual increase in different sample types being picked up across the province through the hubs to the testing points. HIV-1, recency, TB, TB culture, DRT, and HPV histopath samples have successfully been integrated. CD4 chemistry and hematology have not been fully integrated yet, for reasons that have to do with inconsistency of reagents and consumables and awareness. And what we would want to note here is that COVID-19 samples have a totally separate mechanism. And the turnaround time for HIV-1 recency has been maintained between 3 to 7 days. TB and histopath improved from 20 to 24 days to 8 to 16 days. HPV is at 6 to 10 days at TAT. And while VL and EID, I think, have one of the best TATs of between 9 to 12 days. Actually, it's even lower than that. In certain instances, we have VL TAT starting from 72 hours to about 10 days. Next slide. So in conclusion, the successful integration of DRT, TB, HPV into the courier system should improve health outcomes, because the assumption is that as the results come out on time, we assume that the clinical entities will also intervene on time. And so the health outcomes of these clients should improve. Chemistry and hematology samples have not been successfully integrated due to inconsistent availability of reagents. We were not able to measure this very successfully because at a national level, we still have challenges with reagents and consumables. But once that is done, we do not anticipate any problems because samples will just be picked up as per requirement. What we also see is that we will need periodic review of sample movements to monitor performance and ensure all sample types are moving as scheduled. Healthcare providers, as a conclusion, must ensure all samples have access to the courier system. So it's important to note that everyone in the facility was made aware, from the community worker to the clinician to the porter, the pharmacist. Everyone knew that now knows rather that as the courier comes through, they are not only picking up viral load and EID, but a whole host of other samples. Critical to note, and one take-home message is that this integration for us did not cost that much. Why? Because we still maintained the use of the 20 motorbikes and the 3 vehicles. We did not need to add anything to the mechanisms apart from raising awareness, bringing facility staff to a particular point where we could discuss things. And in that way, we have leveraged, taken advantage, and piggybacked on what was already existing. And this model is being now mimicked in Central Province and in the Northwestern Province, and we are anticipating a lot of success. Thank you very much.
Fantastic results. And I think, you know, when we start to talk about integration, we can't really integrate and have person-centeredness unless we're doing this optimization also of the diagnostics. And what a great example of an innovation that didn't cost too much, but that's going to give so much better benefit to the person living with HIV. So I would suggest not only scaling up to other provinces, seeing how to scale up to to the entire country, and other countries picking this up as well. What a great example. And try to get the CD4 on there as well, I would say. Excellent. So we are 4 minutes ahead of closure time. All speakers did fantastically well, keeping to time. Would there be any questions from the audience? Because these are abstracts, they're new evidence, new science coming forward. Happy to take any questions. No? Maybe since we have 4 minutes, why don't we do one sentence each, really? One sentence, 1 minute each. What's going to be next in your innovation toolbox? And we'll go start in my right here.
I think what we learned with this one sentence is that simple is not a bad thing. So I think what we're learning in the innovation toolbox in light of AI and all these amazing things that are coming in is let's keep it simple. Let's go back to basic. It works as well.
Great. For us, it's ensuring that we talk to one another. Sometimes we miss the opportunities because we have not done brainstorming together. And when you do brainstorming together, innovations come up, ideas come up, and this is how we ended up with this.
Thank you. So I think for us, Zimbabwe, like I mentioned, we did this for differentiated service delivery for art, and we saw how well it worked. And at the moment, the program is working on integration. So we are moving into the integration of non-HIV related conditions within the HIV program. And the situation is the same. The M&E system has not yet been fully adapted to give us that information, but we still need to monitor the program. So the same way that we innovated for us to be able to get the data we needed to continue implementation and tracking with DSD models, we are also going to use the same system to cover us as the M&E system is being adapted for integration in the other services that we are also including now. Thank you.
Fantastic. Leveraging what you've learned for everything else that people who are living with HIV or living with other communicable, non-communicable diseases can benefit from. So this is fantastic. It's the way to build a really resilient health system. So let's give everyone a really great round of applause. Thank you for staying with us. And I think we're done now, and we pass over. When do people come back? To the closing ceremony very soon, yes?
Thank you very much, Meg, for standing in for the moderator. A round of applause to Meg. So, colleagues, we are coming to the end of the conference. The rapporteur session and the closing ceremony will start at 12 o'clock. It's been my pleasure managing this plenary hall. I thank you for your cooperation. There were instances where there was only one speaker. There were instances when I had to moderate the sessions, but I think it's been a wonderful experience, and I'm sure you've learned a lot. maybe 16 to 20 scientific sessions that we've had in this hall. So thank you very much. Come back at 12 o'clock for the closing.
Let's have a photo.
Where are your people?
I don't know.